All right, good evening. Welcome to my virtual introduction with Southeast Orthopedics. I'm Dr. Patrick Jones. Thank you for joining me. I'm going to kind of go through my background and some of the conditions I treat, and then I'll have ample time at the end to go through some questions that you might have. So we'll go ahead and get started. Okay, so my background, I'm a board certified orthopedic surgeon. I've been board certified since 2018. I did my undergraduate work at University of Maryland, College Park. I did medical school at Virginia Commonwealth University School of Medicine in Richmond. I did my internship, well, during medical school, I joined the Navy and I did my internship at National Naval Medical Center in Bethesda, and followed that with a residency at Walter Reed National Military Medical Center in orthopedic surgery. I then did a fellowship at Steadman Hawkins Clinic of the Carolinas in Greenville, and sports medicine and shoulder reconstruction. I'm originally from Richmond, Virginia, and I'm married with two children, two boys, 8 and 11. I served 11 years in the U.S. Navy. I was first stationed at Walter Reed, as I mentioned, then was at Naval Hospital, Okinawa, Japan, and then did my last tour here at Naval Hospital, Jacksonville. I also deployed to Iraq in 2019. So what do I treat? So I'm a sports medicine surgeon, so I take care of patients 13 years and older. I take care of athletic injuries to the knee, shoulder, and elbow. This includes taking care of torn or damaged ligaments, tendons, or cartilage in the knee, shoulder, and elbow. I treat a lot of conditions arthroscopically or minimally invasively. These include rotator cuff tears, labral tears, ACL tears, meniscal injuries. I also have an interest in shoulder reconstruction as part of my fellowship, and this involves replacement of the shoulder joint using either an anatomic or a reverse shoulder replacement. And we'll talk about all these conditions. So first off, rotator cuff tears are very common especially for our active population as we are staying active later in life. As most people, the rotator cuff is a series of 4 muscles that surrounds the humeral head. When we talk about the shoulder joint, it's a ball and socket joint with the ball being the top of the humerus or upper arm bone. And there's a series of 4 muscles, the supraspinatus, the infraspinatus, the subscapularis, and teres minor, that attach to that humerus and help pull it onto the glenoid, which is part of the shoulder blade, or scapula, which is the other component of the shoulder joint. And it helps stabilize that shoulder during range of motion so that the deltoid, which is your big muscle on the side of your arm, can elevate your arm. People frequently get tears in these tendons. Most commonly is the supraspinatus, but other tendons are common as well. And you can see this picture on the right. This is an MRI of a torn rotator cuff, and torn tendons tend to retract back to their muscle bellies. And these typically require surgery to fix them. Now, when we talk about rotator cuff tears, they kind of come in a lot of different flavors. So when you look at the picture on the left-hand side, that's an MRI of what a normal rotator cuff is supposed to look like. This middle image shows kind of what we call a partial rotator cuff tear. So you see some increased signal in that tendon, has some torn fibers in there, but it's still largely intact. And then the portion of the tendon on the far right, you can see that is completely torn and retracted. And then we would treat all 3 of these somewhat differently. So an intact rotator cuff or a very minor tear could be treated with physical therapy and injections and have really good outcomes. When they're fully torn and retracted, then we often need to go in and repair those surgically. And I do that arthroscopically. Through 3 to 4 small incisions. We use anchors, which are look like little screws made out of a composite plastic into the bone, and they have sutures on them, and we can use that in a variety of configurations to sew that tendon back down to the bone and allow it to heal with really good outcomes. In some cases, when that rotator cuff is torn or has been torn for a really long time, or is toned too extensively to be repaired, a patient may benefit from a shoulder replacement, specifically a reverse shoulder replacement, which we'll talk about in a little bit, as a means to give them improve their function and decrease their pain. So other structures in the shoulder that can very often give patients trouble is the labrum. So again, talking about the ball and socket joint that is the shoulder, you have the top of the humerus, which is a round ball, and that sits on the flat glenoid. It's analogous to a golf ball sitting on top of a golf tee. And around that glenoid, you have a labrum, which is a soft tissue structure that helps deepen that glenoid and make it confer some stability to the shoulder. And patients can very often get tears in those labrums, both traumatically and degeneratively. Patients will experience pain with pushing, feelings of shoulder instabilities, or very often a popping or clicking in their shoulder with motion. So symptoms that patients might have kind of depend on where that tear might be. It's an anterior labral tear, so in the front of the shoulder. That's typically what patients will experience with a shoulder dislocation, and they'll have continued feelings of instability, and very often they'll have pain in the front of their shoulder. A posterior labral tear at the back of the shoulder. These tend to be more wear and tear injuries, and patients will have pain in the back of their shoulder. They'll really experience pain with push-ups. Obviously saw quite a bit of that in the military, given the population, but anyone could experience that pain. Opening a door might be another situation where you would feel that deep pain in the back of your shoulder, and that would be very characteristic of a posterior labral tear. Superior labral tears can be traumatic or degenerative as well, and that's a pain that's deep in the shoulder, and that's where patients will really experience popping and clicking as they move their shoulder into a position over their head. And these would all be treated differently, sometimes surgically, but not necessarily. Again, injections and physical therapy can be very beneficial for these types of injuries. So shoulder arthritis is another condition that I treat. This really comes in two flavors. There's typical osteoarthritis, which occurs in lots of joints in our body, and shoulder's no different. And this is the loss of articular cartilage or hyaline cartilage in your shoulder. And x-rays are very diagnostic of this, and you can see this in this x-ray over here. This patient has lost their cartilage. They've lost some joint space there, and they've started to develop osteophytes forming off of their humeral head. And this is a patient that would likely benefit from a shoulder replacement. Another version of arthritis is where you have a rotator cuff tear that has been chronic in nature. It's been going on for a long time. This has caused some destabilization of the shoulder, and you actually see it's allowed the humeral head to migrate up into the acromion, which is that bony arch that you feel on the top of your shoulder. And that's had some corresponding degenerative changes to the shoulder joint. And we would treat these with different kinds of replacements, specifically talking about an anatomic shoulder replacement on the left, and this is typically used for glenohumeral osteoarthritis, and a reverse shoulder replacement, which is on the right, and that would be more for cuff arthropathy or long existing rotator cuff tears. And that going back to that x-ray that I showed just previously, and I perform both of these surgeries. So talking about anatomic shoulder replacement, there's been some new technology developed for this over the last couple of years, and it's fairly exciting. Typically, a shoulder replacement was the picture that you see on the right here. We take the top of the humeral head and we remove that and resurface it, and then place a highly cross-linked polyethylene component on the glenoid to reconstitute that bearing surface and eliminate that grinding pain that people will have with osteoarthritis and the associated decreased range of motion. Recently, the new developments have included the advent of these stemless shoulder replacements, and these are much more bone preserving, requiring us to take a lot less bone and with some improvement recovery times. Shoulder resurfacing it continues to be a good indication for the right patient, and these procedures we're more reshaping the humeral head and placing a cap on it as opposed to actually cutting a part of it off. And these, the glenoid we're only replacing a small portion of it. And the correlation with that is that the patients can have a significant amount of range of motion and return to almost all pre-surgical activities with a resurfacing. So talking a little bit about what reverse shoulder replacement is, obviously a total shoulder arthroplasty or anatomic shoulder replacement just replaces what you naturally have with metal and plastic to allow the shoulder to function normally. A reverse shoulder replacement, we're actually changing the anatomy and the way the shoulder works a little bit by taking the ball that's usually on the humeral head. Now we're placing that on the glenoid and placing a cup into the humerus. And what that allows it is it minimizes the need for the rotator cuff, such that the deltoid can power the shoulder alone in the absence of a rotator cuff and restore a near normal function to the shoulder in terms of range of motion using this component. Originally, it was developed for rotator cuff arthropathy, as I mentioned before, but over the last several years, the indications have been expanded to multiple different conditions. One of the most exciting is as a treatment for proximal humerus fractures, which you can see here on the right side of the screen. This allows patients that get these injuries to have a much better recovery than they would have previously with just trying to fix those broken pieces of bone. And often that would lead to poor shoulder function. Additionally, we've seen some patients with normal concentric osteoarthritis have very good results with a reverse shoulder if their rotator cuff wasn't perfect, with greater longevity of the implant. So other conditions I treat are ligament tears in the knee. And so when we're talking about these, I think the most common that everyone knows about it is the anterior cruciate ligament, or the ACL, which you can see here in this diagram. Additionally, the posterior cruciate ligament can become injured. Medial collateral ligament and lateral collateral ligament are typically what we're talking about when we're talking about ligament injuries in the knee. These tend to be very high energy injuries. The knee gives out or bends the wrong direction. Patients feel pop, they have swelling, sometimes inability to bear weight. And really after that traumatic event, they have some continued instability of the knee, as these ligaments are very important in conveying stability to the knee. We see these a lot of times in our athletic population. Here's an MRI, and you can see this is what a disrupted anterior cruciate ligament looks like. Surgically, we usually we treat the majority of these surgically. The anterior cruciate ligament does not, in very rare cases, can it be repaired, but most often we actually need to reconstruct that ligament, which means that we take a tendon from somewhere else in either a donor or somewhere else in the knee, and we use that as a scaffold to allow the new ligament to form in the knee. You can see here, this is what a torn ACL looks like, and this is what a reconstructed ACL looks like using a tendon for graft. Fortunately, we can do all of these surgeries arthroscopically through a few small poke holes. Meniscal tears. Meniscal tears are extremely common. We see a lot of patients get these. They can happen traumatically, but also degeneratively. Patients will usually have pain along the joint line on the inside, outside part of the knee. They can occur a lot of times after a twisting injury, but sometimes people won't remember an actual injury that they had, or it didn't seem to be a big deal at the time when they had it. Knee will swell, and they can have a sensation of locking or catching as the knee moves the range of motion, and we term those mechanical symptoms. Patients will very frequently have pain going up and down stairs. It's obvious it's moving that knee from a bent, loaded position into an extended position will frequently give them pain. So when we talk about the meniscus, it's kind of a horseshoe shape. The lateral meniscus and the medial meniscus are shaped slightly differently, but similar enough that they're horseshoe. And then in cross section, they look like a little triangle. And so then the kind of tear that you can get There's lots of different morphologies to that tear, and that to some degree depends on how we treat it. You can have a longitudinal tear where it splits away from the part of the meniscus that's still attached to the capsule. It can tear in between the leaflets, and a horizontal tear. It can split down through the meniscus. We call that a radial tear. And then there's a whole host of various degenerative tears that people can get. And those tend to be associated with people that have some existing osteoarthritis in their knee or cartilage damage. So how do we treat these? Well, first off, we have to diagnose them. And the best way to do that is through an MRI. You can see on this MRI here, this patient's lateral meniscus here looks like this nice black triangle. And that's what a normal meniscus looks like as opposed to the medial side or the inside part of the knee. Whereas there's this, you can see this horizontal tear extending all the way through the meniscus. And then how we treat these in time of surgery, we do this arthroscopically through a camera and small incisions. This is what a degenerative meniscal tear looks like. And for this one, we just need to kind of remove some of this damaged tissue, clean up the knee, and put it back to a smooth rim of meniscus. As opposed to the center picture, which shows this longitudinal tear in the meniscus. And for these, we would attempt to repair that using stitches to sew it back together. In some cases, patients that have the damage to the meniscus is so extensive, and typically these are patients that maybe have had a couple meniscal debridements over the years, that they have no meniscus left. And that's what this is shown here in this top picture. And for these patients, we may need to do a procedure called a meniscal transplant. And in that procedure, we actually take meniscus from a donor and we sew that in place to reconstitute that meniscus, providing that cushioning effect that meniscus provides to the knee. So cartilage injuries. So this is kind of an interest of mine, kind of under the umbrella of knee preservation surgery. So as we know, with osteoarthritis or cartilage loss in the knee or any joint, that you can have a gradual thinning of the cartilage globally throughout the knee. It just wears down over time, or you can get focal lesions of the cartilage. And when we're talking about these cartilage injuries, we're talking about these focal injuries. And it's analogous to a pothole that forms in the road. And we have various techniques to repair those potholes in the cartilage and restore that cartilage surface and prevent the progression into osteoarthritis, which we know that these small potholes will grow over time if untreated. And those treatments depend a lot on a lot of different things: size of the lesion and location of the lesion, patient age, overall joint health, limb alignment, patient's BMI, and their ability to tolerate a rehab protocol. The picture in the middle, this is what these cartilage lesions look like. And this one's actually been, had a procedure done called microfracture, where we break some holes through the bone underneath that cartilage. That allows mesenchymal progenitor cells to elute out from the bone marrow and actually form a cartilage-like substance called fibrocartilage that fills that defect. It has some wear properties similar to hyaline cartilage. This has been done for up to 30 years, and patients have had really good success. But it does have to have some certain indications to those procedures. Exciting new techniques that have been developed is cartilage transplant, and we can either take cartilage from a part of the knee that doesn't bear weight and place that into these defects as a plug. And sometimes we can also take that cartilage plug from a donor if it's large enough, or it needs to be larger than what we can get from the native knee. Additionally, now there's a technique that has been developed over the last 15 years or so that we've been doing, where we can take cartilage cells from inside the knee, and this actually requires 2 surgeries. During an arthroscopic procedure, take those cells and they're grown in a lab and expanded, and those cartilage cells, which are called chondrocytes, are grown up and expanded, and we can actually then take them back at a secondary surgery and implant them into the defect. And this can regrow that cartilage in the knee and fill in that defect. So that's a little bit of overview of some of the things I treat. Where do I practice? So I'm based in St. Augustine with Southeast Orthopedic Specialists. Our office is on South Park Circle. It's right across the street from Flagler Hospital. I do my surgeries at the brand new Ascension St. Vincent's, St. John's on 210. This is a brand new facility. It's state of the art, and we're all really excited to get going and help the people of St. Johns County, Jacksonville, and St. Augustine there. So with that, we'll go ahead and take some questions, I think. Yeah, so that's a great question. I always get, what's the recovery going to be like after a rotator cuff repair? Typically these are same day surgeries. Come in the morning and you go home that day. I keep my patients in a sling between 4 to 6 weeks, depending on the size of the tear. Larger tears are going to require a longer period in sling. I like to begin physical therapy almost right away. And obviously you can come out the sling for physical therapy, but I like to keep you in it to protect you. Over the next 3 months of physical therapy, you're working on regaining your range of motion and your strength in your shoulder. I expect most patients to have their full range of motion by about 3 months. And after that, it's just working on strengthening and getting back to normal activities. I would say most people have full recovery by about 6 months after surgery. Yeah, so that's a great question. So lots of people are concerned about how do you know that you have a torn rotator cuff versus you just have bursitis or some tendonitis or something else. And really the telltale sign that you should be concerned that you may have a tear in your cuff and actually maybe a big tear in your cuff is weakness. Pain in your shoulder can be caused by a lot of different things, but if you have trouble lifting your arm above your head, it just feels weak to you. That would be very concerning that you have torn one of your rotator cuff tendons, and we would want to evaluate that sooner rather than later. Yeah, athletes are an interesting case because a lot of times they're going to feel really good after a couple months and want to get back on the field, and we have to kind of hold them back a little bit while that tendon that we use to reconstruct their graft, or that tendon we use as a graft to reconstruct their ligament, is going through the process of called ligamentization, and it's regaining its stability. So typically an athlete will be after the initial post-op period and they've been through physical therapy working on regaining their strength in the muscles surrounding their knee that help stabilize their knee. I'll typically let them get back to doing some jogging and light running at about 3 months. By about 6 months, we start what we call sport-specific training. That's where we allow them to start cutting side to side, jumping, and things like that. Return to competitive sports, like being on the field again, is kind of it's going to be closer to the 9-month mark. There's a lot of metrics that we look at during that time of what they can do, and with a lot of input from our physical therapists to let us know that that athlete is ready to get back on the field, and they have to pass a lot of physical tests to prove that. But usually kind of about the 9-month mark is where we would expect them to be back on the field. So the best, particularly when we're talking about shoulder issues and patients have pain in their shoulder, I always say that the only thing worse than a painful shoulder is a painful stiff shoulder. So the best thing that people can do if they hurt their shoulder is working on getting their range of motion, stretching, things like that. Additionally to that, there's a whole host of rotator cuff strengthening exercises that can be found on the internet or through one of our physical therapists, and keeping your rotator cuff strong, even if you have a rotator cuff tear. We've seen again and again that the rotator cuff has the amazing ability to compensate for itself, so that the other muscles of your rotator cuff, even if you've torn one of them, can compensate for the others. So there's definitely value in strengthening your rotator cuff, even if you have a rotator cuff tear. Yeah, I do. I think PRP is fascinating. I think there's a lot of science out there that is starting to really push the benefits of PRP. But we have to be careful about when we talk about this. It's not a regenerative medicine. It doesn't regrow anything, but it has this tremendous amount of anti-inflammatory capabilities to it, or pro-inflammatory if that's what you need. And that depends on how we concentrate the PRP. There's really good data out there that shows that it's beneficial in knee osteoarthritis or partial thickness rotator cuff tears, lateral epicondylitis or tennis elbow. It's has a long-term data supporting that. So yeah, I do offer PRP injections, other regenerative solutions, including hyaluronic acid, if the patients have, if you have the right indications, and that's a conversation that I'm happy to have with any patient about whether I think they would benefit from it or not.